Hello, everyone, and thank you for joining us today. My name is Carla Alegria with the National Center on Domestic Violence, Trauma, and Mental Health. Today's webinar is Trauma-Informed Addiction Treatment for Women. Our trainer today will be Dr. Stephanie Covington, an internationally recognized clinician, author, organizational consultant, and lecturer. Dr. Carol Warshaw, Director of NCDV-TMH, will be facilitating this session. Before we get started, I would like to go over some technical details of the WebEx software that we'll be using for today's webinar. Many of these details are explained on using this webinar system tab in the center of your screen. You can switch to the screen from the slides by clicking the down arrow next to using this webinar system. Please be aware that your screen might look a little different depending on whether you're using a Mac or PC. On the right side of your screen, there are multiple boxes. Second from the bottom is the chat feature. This feature will allow you to provide feedback and share resources with your fellow colleagues, as well as get contact with trainers or myself if you have questions regarding the training content. You may contact Angelica Medina, also at the center, if you have questions troubleshooting the WebEx software. To do this, click on the down-facing arrow and select the person you would like to contact. You'll see a lot of options, but for this session, you'll want to select all participants if you would like to respond to a question from the trainer or to contact me anytime during the session. You should click on Angelica Medina to privately contact her if you are in need of troubleshooting the WebEx software. So let's test this chat feature. Will everyone please go to the chat box, click on all participants, type in where you're calling from, and then press enter. Perfect. Thank you all very much. While folks get a lot out of this chat, there are times that it moves really quickly and can feel distracting. If this is true for you, feel free to minimize the chat box by clicking the arrow next to where it says chat. You can also open it again with the same arrow if you choose. We'll be providing live captioning during this webinar, but the chat box, below the chat box, there's a media viewer box. This will contain the captions. If you don't want to see the captions, click on the down-facing arrow next to the word Media Viewer, the same way you might if you want to hide the chat box. I will be moderating the Q&A at the end, time permitting. And at the very end of the webinar, you'll be taken to a brief evaluation. Please take a moment to let us know what was useful and what could have been better. If you get disconnected at any point, return to the email you received with the original webinar link and re-enter the training. Sometimes the sound cuts out due to internet connection, so feel free to call in if that's the problem for you. If you're experiencing technical difficulties and are unable to contact Angelica Medina, you may call WebEx tech support to resolve any issues. That phone number, which I'll post in the chat box, is 1-866-229-3239. Again, thank you for joining us today, and I will now turn it over to Dr. Warshaw.
Thanks, Carla. And as Carla said, we're really pleased to have you join us for this joint webinar series on opioid trauma and DV, co-sponsored by National Center on Domestic Violence, Trauma, and Mental Health, and the Campaign for Trauma-Informed Policy and Practice, which I'll refer to as CTIP. CTIP's a national organization that was created to address the impact of trauma across the lifespan and to work in partnership with individuals, communities, cities, states, tribes, and federal policymakers to promote trauma-informed resilience and prevention-focused policies and practices, and to help us all work together to create a just, equitable, and trauma-informed society. NCDV-TMH, as many of you know, is the U.S. Department of Health and Human Services Administration, Children and Families, Family Violence Prevention and Services Administration-funded Special Issue Resource Center on, not surprisingly, domestic violence, trauma, mental health, and substance use. And our work is partly promoting accessible, culturally responsive, and trauma-informed approaches for the DV field, and accessible, culturally responsive DV and trauma-informed approaches for the mental health, substance use, and behavioral health field, as well as legal and child welfare. And we're also engaged in a lot of work around, we provide a lot of training and technical assistance and resources, research, policy, and public awareness. So both organizations that I'm actually on the board of CTIP as well, joined together to produce this webinar series on these critical intersecting issues. From CTIP's perspective, partly highlighting the role of trauma across the lifespan, including adverse childhood experiences on substance use and addiction, and the importance of taking all of this into account in developing interventions, treatment, and policy. And from our perspective at NCDV, TMH also add all of that plus the additional layer of coercive control in the context of intimate partner violence. Some of you may be familiar with a study we did with the National DV Hotline, which found over 3,000 callers, 27% said they were coerced into using. And of the 15% who had sought treatment, 60% said their abusive partner, current or former partner, had tried to interfere with treatment or sabotage their recovery. And then 37.5% said their partner then turned around and used that against them around custody or protective orders. So part of our role in this is to make sure that that layer of understanding around coercion and IPV and also coercion into human trafficking are part of the picture when we're thinking about trauma and addictions. So some of the other webinars in the series on September 24th, Lisa Najovitz will be talking about peer-led seeking safety. Sometime this fall, Beth Collins from Colorado will be talking about adaptations of seeking safety for DV programs. In October on the 18th, we're going to be doing a webinar on the neurobiology of trauma and the neurobiology of addiction. We'll do one on social determinants of health and their impact on the opioid epidemic. We'll also do ones that are featuring promising programs and practices that DV programs are doing or partnering with other people in their communities and states to address these complicated issues. So without further ado, I'm going to introduce my dear friend and colleague, Dr. Stephanie Covington, whose pioneering work has been instrumental in the development and implementation of gender-responsive and trauma-informed services in both the public and private sectors. So she's not only played a critical role in raising awareness of the importance of a trauma-informed, gender-responsive approach to addiction treatment, she's also been a leader in creating the tools and resources to do so, including 8 manualized treatment programs, many of which are evidence-based. Dr. Covington served on the faculties of the University of Southern California, San Diego State University, and the California School of Professional Psychology, and she's the co-director of the Institute for Relational Development and the Center for Gender and Justice. So, Stephanie, I'll turn it over to you.
Thank you, Carol. Can everybody hear me okay? Yes? Okay. I guess I'm not going to get an answer. Well, it just shows my mic is on my screen. It shows that I'm muted, but I'm going to assume that's not happening. So thank you very much, Carol, for the introduction and for the invitation to be able to talk to you about trauma-informed addiction treatment for women. And where I'd like to start is to sort of give us a quick history and overview of how we have evolved over time in thinking about treating women. That originally, addiction treatment was very generic. Men were seen as the client. That was in the 60s. But in the 70s, and basically because of the women's movement, we began to talk about some gender differences as they related to addictive disorders. And it came out of the women's movement because as women came together in small consciousness-raising groups, they began to tell the truth about their lives. And they began to talk about childhood sexual abuse, they began to talk about domestic violence, they began to talk about addiction to alcohol and other drugs, a whole variety of things that very often their mothers had never spoken out about publicly. And so, of course, we got our first DV shelter in the 70s, but we also got our first treatment programs that were designed specifically for women. And then by the 80s, people started talking about gender-specific treatment. I can tell you that what that meant was something different for all different places. I would visit programs that said, oh, yes, we're gender-specific, and that meant that the women were in a women's group 1 hour a week, and they were using exactly the same materials the men did. And so we realized we had to become clear about what we really meant in terms of women-centered services. And we began talking about being gender-responsive and looking at trauma. And so when we move today, and what we've been doing since about 2010 until now, is we talk about being both gender and trauma responsive, and looking at the multiple issues that are involved in women's recovery. And so some of the other changes over time around addiction, initially when people provided services for addiction, they were focused on substances, alcohol and other drugs. But over time, people began to realize people could have what we call addictive behaviors or process addictions, such as gambling, sex, exercise, money, a whole variety of things. So substances was where we started, but now we have expanded our definition and understanding of addictive disorders. And some of the definitions have changed. The DSM-4-TR used substance abuse and substance dependence. The Diagnostic Manual 5 talks about substance misuse and substance use disorder. Our National Institute of Drug Abuse talks about addiction as a brain disease because as we've had more sophisticated brain scans, we're understanding more about the impact on the brain. And the definition that I've developed and used, it's the chronic neglect of self in favor of someone or something else. And so these are just some of the ways in order to begin to conceptualize and the various concepts really to pull together. Now, neuroscience, and because of, as I said, our more sophisticated understanding of the brain and understanding, yes, okay, it's a brain disease, and part of what happens is alcohol and other drugs have the ability to really impact and actually hijack the reward pleasure center in the brain. It brings about positive sensations, and what happens is nothing else becomes as compelling. And so the alcohol or the other drug, whatever the addictive substance is that someone is connected to, if you will, now takes over in terms of anything like relationships or exercise or other joyful activities that someone may have experienced in their life no longer is quite as important as their attachment to their drug of choice. And neuroscience has also brought us medication-assisted treatment, that because of the understanding of the brain, drugs have now been developed that can help in drug treatment. What this does is it reduces the craving. Many people keep hoping that medication-assisted treatment is the silver bullet, that, aha, now we have a drug that's going to create the cure. I really want to emphasize that these drugs are incredibly important. In many cases, because of being on this medication, a person is then able to participate in more comprehensive treatment. So the medication itself is important, but it is not a silver bullet. It is not the be-all, end-all. The other thing that I think is important when we look at addiction in our society is realize as our research has progressed and we've become more sophisticated, our response has actually been to criminalize addiction. So we know if we look at the rapid increase in the incarceration of people in our jails and prisons, and you begin to look at their histories, we very often, and particularly for women, see women who are there because of their use of substances, and often for women, they have committed low-level crimes in order to be able to fund their drug usage. So people always say, okay, well, how does somebody, you know, become an addict, or what are the risks? What are the things that seem to be connected? And again, there's no simple answer. There's no one answer that's for everyone. 50% is a genetic predisposition. People who come from families where there have been family members addicted to alcohol and other drugs are at greater risk, but this is the same kind of genetic predisposition that we see with other disease processes. It doesn't mean it's necessarily going to happen to you, but it does mean you are at risk and need to consider prevention. We also know that toxic or traumatic stress in childhood also increases someone's risk. Experiencing abuse and violence in their lives, both as children and as adults. Beginning to use substances at an early age. The earlier that someone begins to use in their life, the greater their risk. So that we have some women who began to use at a very early age, sometimes even introduced by parents, preteen age. Certainly teenagers use alcohol and other drugs recreationally, but that increases their risk of what's going to happen later in life. Also, who do you spend time with? If you're spending a lot of time with people who are using alcohol and other drugs, that also puts you at risk. And what are your coping mechanisms? If you're a woman who's using alcohol and other drugs as your main way of coping, that's going to put you at risk. Having high levels of stress in your life, adversity, poor nutrition, chronic illness, dealing with grief and loss, and basically dealing with any kind of painful feelings. I mean, using alcohol and drugs for some people, they're using it as a solution to another problem, and then the solution becomes a problem. So we can see there are a whole variety of things in life that puts a woman at risk. We also know that women are the fastest growing segment of substance users in the United States. And we particularly see changes when we look at young women. If we went back 15, 20 years ago and we looked at adolescents, we would see that teenage boys used much more than teenage girls. Today, we know that teenage girls are at greater risk of being binge drinkers than boys are. So there has been a shift in who's using, how much they're using, and again, women, girls are using at a very high rate. So when we begin to look at substance use and we begin to talk about trauma, we see that women's rate of childhood sexual abuse, which is one of the high-risk factors for addiction, are 3 times as high as men's rate, and that this form of abuse, as I said, is really connected to women's use of alcohol and other drugs. And women's drug use is what we call socially embedded. There's really a relational piece connected to this. Couple of things that we've learned. Some women begin to use alcohol and other drugs to maintain a relationship. These would be women who say, well, you know, I never drank much, but he went to the bars on Friday and Saturday night, and I started to go with him. Or he began to use a particular drug, and, oh, so I started using with him. And there's this kind of feeling that if I'm not using with him, he'll find another woman who will. Men do not adjust their alcohol and drug use to match that of their female partners, but women often do this to match the use of their male partners. Some women are using alcohol and other drugs to fill in the void of what's missing in a relationship, of the needs that are unmet, particularly emotional needs. And women can also be using alcohol and other drugs to self-medicate the pain of abuse of what's actually happened in relationships. And then Carol also mentioned the piece earlier about the coercive aspect of what happens to women who are in abusive relationships and this coercive use, and certainly also what we know about drug use connected to women who are being trafficked. Another way to think about this connection between addiction and relationship is addiction is a kind of relationship. A woman is in a relationship with her drug of choice, and initially this starts out as a love relationship. She's getting something positive from it. Usually it's helping her feel better or at least feel less stressed, and she's liking what the effect will do. And then it becomes a love-hate relationship, and that's where things obviously become problematic. I think another way to think about addiction conceptually is, in French, the word addiction means nailed to. And so if you can think about this relationship and a woman feeling like she's nailed to her drug of choice, And how we think about treatment is how do we help her disengage or disconnect from that. And we all know that ending relationships often isn't easy, even if it's not a great relationship. Well, ending this relationship, the drug relationship, is also not an easy process, a more challenging process. When we look specifically at prescription drugs, as people are doing today because of what's happening with opioids, prescription drug use and the use of prescriptions in non-medicated ways has always been a greater risk for women. And that's because women use more health care than men. And if you're using more health care, you're at greater risk to get a prescription. And they also have done some studies where they've had both men and women with exactly the same presenting health issues go to health care providers. And what they found is women were more often given a prescription, and men were more often given x-rays and other kinds of diagnostic services. So just by using health care alone, women are at greater risk to receive a prescription. And then certainly we know, particularly with pain medication, that these are addictive drugs. And it's so interesting that so often when a new drug comes out, very often the public is told, well, this is non-addicting, and then over a number of years we find that, in fact, there are certain risks, and very often they are addicting. And then you can imagine what happens when a woman begins using a prescription, let's say as a painkiller, and she becomes dependent on it. She can no longer get the prescription, and then there's the risk of then trying to get the drug or something similar on the streets. So when we look at opioids in women specifically, we see that both childhood sexual abuse and parental separation are highly correlated with opiate use in women, and that they have been disproportionately affected by the opioid epidemic. That they represent a 400% increase in prescription opioid-related deaths compared to a 237% increase in men. I mean, both these increases are really astronomical, but again, we see the difference between men and women. So when we talk about trauma and as we talk about addiction, it's very important that we consider gender, and that in doing addiction treatment, both issues have to be taken into consideration. And you'll notice I keep saying male, female out of habit, really. But in today's world, when we think about gender, we really need to consider a continuum, that we now have a significant and more visible transgender population. We have people who are gender nonconforming. We have new language about cisgender. So gender as a concept has also changed over time, and we no longer think about this only in a binary way. One of the things, as I was showing you earlier, the definition or this evolution, if you will, of treatment for women and trying to think about what it means to be gender responsive, there are really two key pieces when we think about treatment. One is the environment of any place that's providing a service, the environmental, or what I would use environment as well as physical environment, but also the culture of the place, the feeling of the place, but also the programming, the content and material. And how we think about creating an environment, we have to think about the site and what that actually looks like, or the physical environment, and where we've placed the services, if they're in a safe location and easy for women to get to. Staff selection, who should be working in women's treatment programs. Years ago, we said and believed that only women should work with women, and then we found that there were women that really shouldn't work with people. And so it isn't just about having an all-female staff. It's also having staff that want to work with women for the right reasons, people who like women. Program development. How do we develop our programs? What does that mean? A lot of programs just people get grant money. They have to be up and running. They create a schedule, and we have a lot of activity-driven schedules without really thought to really asking the question, when a woman completes this program, what do we want her to leave with, and then back mapping into that. And the content and the material, does it relate to women's lives? Does it relate to girls' lives? It isn't just taking men's material and changing pronouns. It's really thinking about materials through the lens of gender. And all this needs to reflect an understanding of the realities of women and girls, their lives, and address and respond to both their strengths and their challenges. So these are some of the things we think about as we're developing services. And with trauma, we have to think about gender differences also. And again, if you look over the lifespan, we begin to see some of these differences, that we know that boys and girls are at risk for harm from family members and people they know, much more at risk there than from strangers. But the differences begin to become more obvious as we move into adolescence. And there, young men are particularly at risk of harm if he's a gay young man, a young man of color, if he's a gang member, a young man who's transitioning. And then his greatest risk for harm comes from people who dislike or hate him. And we contrast that to what happens to a teenage girl, where her greatest risk for harm comes from the person to whom she's saying, I love you. And so again, you can see this relational piece and how this plays out a little differently. For men in their adult lives, if they serve in the military, their greatest risk for harm comes from the enemy. If they're living in our communities, their greatest risk for harm comes by being victim of crime committed by a stranger. For a woman in her adult life, her greatest risk for harm, if she serves in the military, is harm from the people she's serving with. And if she's living in our communities, her greatest risk of harm comes from her relationships. So when we work with men with trauma histories, of course, the majority of men who have addictive disorders, who are in addiction treatment, do have histories of trauma. But it's very unusual to work with a man who was harmed by someone he was in a relationship with. He was in a relationship in his childhood, and then in his adolescence was harmed by someone he was in a relationship with, and then in his adult life was harmed by someone he was in a relationship with. That's an unusual scenario for a man. It's a very common and typical scenario for a woman. And then what we also know is that the LGBTQ population, people who are gender nonconforming, are actually at the highest risk for abuse and trauma in our society. We also know a lot now about toxic stress and the stress of adversity. And because so often with kids we get focused on the physical abuse, the sexual abuse, and the emotional abuse. But what we've learned, and this again comes back to brain development and what we've learned from neuroscience and the brain scans, that there are certain points in life where brain development is particularly important. One is in utero, the other is the first 5 years of life, and the other is in adolescence. And toxic stress, compared to that normal stress that most of you know about in your life, toxic stress is the kind of stress you cannot get away from. You can't take a vacation from. So toxic stress can come from poverty, chronic hunger, a child growing up in a family with a parent who's who might have a substance use disorder with alcohol, other drugs, growing up in a family where there's domestic violence. So there's this toxic stress. And so growing up with these adversities, and also, by the way, racism, sexism, again, things you cannot escape, is toxic to the development of the brain. And what we've learned with children, it impacts in particular 3 parts of the brain, the part of the brain that has to do with emotions. So we see difficulty with regulation, part of the brain that has to do with behavior, and children have difficulty managing behavior, and relationships, that they struggle from lack of connection and a sense of trust. So again, another form of challenge with trauma, and then when children are experiencing these things, this is part of what puts them at risk for using alcohol and other drugs later in life. So let's kind of look at what happens here. So process of trauma, you have the event. It overwhelms a woman's capacity to cope. It overwhelms her physically and psychologically. And a number of years ago, we used to be focused much more on the psychological aspects, but today we also understand the physical component to this. While the initial response to trauma can be this fight, flight, freeze response, and this is where someone often feels numb. It can be psychological numbing, physical numbing. They may be hypervigilant, always scanning the environment to see if they're safe, hyperarousal, feeling kind of revved up. But these initial responses to trauma now begin to shift over time, and the person develops a sensitized nervous system. And there are also changes in the brain, changes in terms of brain chemistry, change how the brain is functioning. And there's a brain-body connection. This is not the same as mind-body, but the brain, of course, allows us to do all kinds of things. It's sending messages to our body all the time. So this brain-body connection also becomes impacted by the experience of trauma. And then we see a woman who now has some form of psychological and physical distress. And there could be current stresses in her life. It could be something as being admitted to a residential drug treatment program. It could be the process of being arrested. It could be having a child that's very ill. It could, all kinds of stressors. It could be that she's been triggered by a reminder of the trauma. There may be images that she's seen. There may be sensations she's felt, feelings, memory that are reminding her of what happened in the past and pushing her back in time, so she's flooded by feelings connected to this past experience. And then we see various emotional and or physical responses. The retreat responses are what I would consider our mental health responses, the isolation, the dissociation, which is the mind-body split, depression, and anxiety. So we have our mental health responses. We have the harmful behavior to self, and this is where we would see the substance use disorders, the eating disorders, the deliberate self-harm, and the suicidal action. We have harmful behavior to others. This is where we see the aggression, the violence, the rages, and on the far right-hand side, the physical health issues. And so here we see all these issues that are very often what's underneath them is trauma, and yet we have a lot of service providers who are providing services for mental health, for substance use disorders, anger management programs, physical health services, without considering what's underneath. And the addiction field for years has not wanted to, we've known for years that many of the people seeking services had trauma histories, but there was a mantra, we don't deal with trauma here. When you're clean and sober for a year, then you can work on that issue. Well, of course, many women never got a year of recovery because the trauma was so linked to their substance use that they were unable to have any kind of lasting recovery. So what we're trying to help service providers, both mental health service providers, physical health care providers, addiction treatment providers, begin to understand is so often you have to also look at what's underneath, whatever someone may be presenting with at the time. Now, the ACE study, when we look particularly at the physical health part, I'm sure many of you are aware of the Adverse Childhood Experiences study, where initially, actually here in San Diego, they asked 17,000 people 10 questions having to do with their life before age 18. So emotional abuse, physical abuse, sexual abuse, physical and emotional neglect, growing up without parents, mother being treated violently, a family member who was using alcohol or another drug, mentally ill family member being imprisoned. And they found that these 10 questions that of what people had experienced before the age of 18 were still having an effect 30, 40, 50 years later. And that first they looked at alcoholism, the injection of illegal drugs, smoking, and obesity. And they found that people that had a score of 4 or more yeses on those 10 questions were the people later in life that were struggling with 1 or more of those 4 items. And then they went back and looked at chronic health care issues, some of those illnesses, the heart disease, the autoimmune diseases, and they found that people, again, who had a higher ACE score were people later in life who were struggling with chronic illness. So the ACE study helped us a lot, particularly also with looking at those substance use disorders. But because the study was done in San Diego, they took the same study to 26,000 other people, 5 different states, a better diverse sample of Americans, and they found the same kind of results. Chronic depression, suicide attempts, serious and persistent mental health challenges, and addictions were all related to these high scores for on the ACE study. They also, now you know, many providers, when you talk to them, and this is often said in substance use disorder treatment, oh no, we can't talk about trauma because we can't open that can of worms. Everybody will melt down. Lots of reasons why not to do it. But it's interesting, at Kaiser with this first group of people, if they had a high score, they each got an hour with a mental health professional. And that session started with, I see you have, whatever they checked off, and tell me how this affected you later in their life. And actually, people were surprised to be asked. People said things like, you know, I've never told anybody this. And when they had these sessions, they actually found that it was useful to people. They found that it helped people. Because of their concern that these questions would be difficult for people, a pager was carried by a staff person 24 hours a day, 7 days a week for 3 years. Not one of the 17,000 people had a meltdown and had to call somebody. So what they found, in fact, that by asking and bringing these things up, it was actually helpful to people. The other thing that was found, that women were 50% more likely than the men to have a score of 5 or more. And as we said, these experiences increase women's risk for drug use. So when we look specifically at opioids and the ACEs, women with 5 or more ACEs are 3 times more likely to be using prescription medication not as medically prescribed, and they're 5 times more likely to be injecting drugs. And as I said earlier, the number of women who have died from overdose in that 1 10-year period from 2010 to 13, overdoses tripled. Same study, quick slide, was taken into the prison setting. Remember, I talked earlier about how we have criminalized addiction. A score of 4 or more yeses for women in the prison indicated they had higher rates of physical and mental health problems. And if a woman had a score of 7 more yeses on those 10 questions, it was a 980% increased risk of having a mental health problem. So again, we constantly see how trauma is connected both to mental health problems and specifically to addiction. So every time we look at women with any kind of addictive disorder, we see adversity and we see trauma. And so when we begin to think about treatment, we have some major challenges historically. Historically, addiction treatment services were designed by men for men. Women were an add-on. In today's world, we do have some services in various parts of the country designed for women specifically, but that is not available in every community. Our mental health services were originally designed by men for women, and so again, they very often aren't, but they weren't designed for women, really considering the issues of gender and trauma. If we look at criminal justice services, these were designed by men for men, although we have a substantial number of women in this country incarcerated. And we know that criminal justice services have been designed for people who victimize others, even though the majority of the people, male and female, who are in our prisons are also victims. And so any of you who've worked in any kind of an agency or provided any kind of a service, you know how difficult it is to undo things compared to if we started from scratch knowing what we know. So part of our work today when we talk about treatment services is to begin to undo the old and to bring in the new. So some of the definitions, I know this concept or the wording trauma-informed, it's language that is used all over. It has really resonated with people. It's been picked up, and people are very proud to be trauma-informed. Often people don't know what that means. I've had people tell me, oh, yes, our agency is trauma-informed. 2 of our counselors went to a weekend training. When we talk about trauma-informed, we are talking about having knowledge about adversity and trauma and how it impacts individuals, communities, and society. Being trauma-informed is really what we know. But then being trauma-responsive is how do we take what we know and implement it. So trauma-responsive is about having policies and practices in place that minimize harm and maximize opportunities for growth and development for everyone. It's really about creating an environment for healing and recovery. So trauma responsive is what do we do with what we know, and very often this is where service providers are having difficulty. Trauma specific, these are services designed to specifically address violence and trauma and to facilitate healing and recovery. So trauma specific is about what we provide. So many places that provide services need to become both trauma-informed and trauma-responsive, but they may not be providing specific services. So what would a trauma-informed women's treatment really look like? Number one, all staff would be trauma-informed. This means all the staff would have an understanding of trauma. Van drivers, call centers, people, if it's residential, people working in the kitchen, everybody on the staff would become trauma-informed. And then a trauma-informed women's treatment program would also be trauma-responsive. They would use a trauma lens to look through when providing services for understanding a woman's history, of beginning to see that many of the things she's been using as coping strategies, such as alcohol and other drugs, understand trauma and understand this as a coping mechanism. Trauma responsive also means you would look at your environment or the culture of your program. It might be something as simple as the signage. So let me give you an example. This is a sign that was in a women's treatment program. Attention, giving tox screens is not optional. Effective immediately. If a client's on the tox list and leaves 2 consecutive times without giving, she may be discharged. Well, that's pretty clear. That's a sign. This is the same program becoming trauma-informed and then moving into trauma-responsive to all of our Lifeline clients. Kindly check the tox list at the front desk for your name, both before and after group. If your name is on it, it means we're requesting that you provide a tox screen before you leave the building. If you have any concerns, please do not hesitate to discuss them with your clinician or Terry, Lifeline's case manager, appreciatively. So just look at the difference between this sign and this sign. That's about changing how we do things. How about this sign? Big banner in a treatment program for women. Denial ends here. But as they began to understand trauma and think about the culture of their program, they changed the banner to Hope Starts Here. Again, notice the shift in tone. So when we talk about environment, we're talking about the physical plant, of course, but we're really talking about the culture of the program, the tone of the program, how it feels to people to be there. Trauma-informed women's treatment also means comprehensive services. That initially, addiction treatment was set up as a single-focused intervention. We deal with substances here. But what we know is that the use of alcohol and other drugs is usually embedded with a variety of other issues and considerations. So services need to be comprehensive. You need to have the ability to deal with trauma. There may be issues around homelessness, mental health, HIV and AIDS, other health problems. So again, the services need to be comprehensive, not single focus. That's how we did treatment 30 years ago. And then there need to be some trauma-specific interventions. And I think there's really three primary things that trauma-specific interventions need to be able to do. One, we want women to have an understanding about what abuse is and about what trauma is. Even though this may be part of their history, often women are unable to name it. They're unable to acknowledge it. And part of what's important about being able to name something, whether it's an experience that you've had in your life or whether it's the problem you're having with alcohol and other drugs, when we can't name something, if we can't name something accurately, we don't have the capacity to really deal with it. And so learning what these things are is an important part of the recovery process. Understanding the impact that we've learned that even sometimes teaching a woman about what is post-traumatic stress disorder, women will say things like, oh, you mean there's a name for that? I've been hiding this all my life. Oh, I just thought I was crazy. So when women, even that process of trauma chart that I showed you that I've used for a long time in training, we've begun to give that to women in treatment settings. And the women say it helps them connect the dots in their lives. It looks like a lot of, information that perhaps a woman wouldn't be interested in, but women find that really helpful to understand the impact of life events on all the aspects of who she is. And the third thing that's important, I think, in a trauma-specific intervention is providing grounding and coping skills. And grounding techniques are things that can help a woman be in the here and now. When I mentioned triggers before, as I said, it throws a trigger. Something happens, sight, sound, smell. It pushes the woman back in time, so she's flooded by the feelings related to the traumatic event. If she has grounding skills, that helps keep her in the here and now. She also needs coping skills. The use of alcohol and other drugs for many women has been their primary coping mechanism. If she's in a treatment program, the idea is to separate her from the alcohol and the other drugs that are causing problems in her life. But we have to be teaching her coping skills, or she will go back and use the coping skills she's always used. And so an important piece of addiction treatment is teaching coping skills. And that needs to be a really important part of a trauma-specific intervention. So here's some materials that I've created for women. I'll give you a little brief synopsis of them. Helping Women Recover, which is a program for treating addiction. We have a version for women in the community. We have a version for women in the criminal justice system. Beyond Trauma, a healing journey for women. Healing Trauma, which is a brief succession intervention. Beyond Violence is a prevention program for criminal justice-involved women. Actually, there's another program on here called Beyond Violence and Beyond Anger and Violence, and that's a program for women in the community. So helping women recover, the primary focus is on addiction. The sub-theme in this is trauma, 17 sessions focus on exercises, interactive exercises dealing with self, relationships, sexuality, and spirituality. These are 4 areas that women say change the most from addiction to recovery, and they're also the areas that they have high risk for relapse. So that's helping women recover. You'll see there's 3 theories that ground, the 3 theories I've integrated to ground this intervention. One is a theory of addiction, one is a theory of women's psychological development, the relational model from the Stone Center, and theory of trauma. So these 3 theories create the foundation for helping women recover. And the model that I use for addiction, I gave you the definition earlier, but I do consider addiction a disease, but I think about it from a holistic health model of disease. And so I look at the physical aspects, the emotional aspects, the social, the spiritual, and then also the environmental and political. And when we look at men and women who have addictive disorders, we see differences in each one of these categories between men and women. So that gives you a sort of a thumbnail on helping women recover. Beyond trauma, this is a trauma-specific intervention, focuses on trauma, sub-theme here. So helping women recover, primary theme is addiction, trauma is a sub-theme. Beyond trauma, primary focus is trauma, addiction is a sub-theme. 12 sessions, 3 modules, helping women learn about violence, abuse, and trauma. Second part is looking at the impact, and the third part is the healing aspect. All the materials have a facilitator guide and a participant's workbook. This particular intervention also has DVDs, 2 training DVDs, and then 1 for the women's group. Healing Trauma is an abbreviated version. This is a 6-session intervention. Everything's on a CD so that you can duplicate the facilitator guide and the workbook as many times as you want. Workbook is in English and Spanish. I have to tell you that originally this was a brief intervention was developed because a women's prison wanted something brief. I asked them to attach a researcher to it because I thought a brief intervention probably won't do anything. I was absolutely wrong. We can do a lot in 6 sessions. So you can see the topics that we work on in each of the sessions of healing trauma. And you can find more information on these things on my website, and on the home page there's a prompt, a link that says research, and you can read about ongoing research on all of these. Beyond Violence is a program for women who have actually committed violent, aggressive crimes, and it works on 2 levels. It works on the violence and the aggression that they have experienced, as well as what they may have done themselves. So we're working back and forth here. Again, this is a program that was requested initially from a prison because there's been nothing for women who committed violent, aggressive crimes. And without surprise, I'm sure to anyone, these women very often had incredibly abusive histories. So 20 sessions, 4 modules. This works on a model of violence that's used by the World Health Organization and our Centers for Disease Control that look at 4 areas. The individual, their relationships with others, the communities they live in, and the society they live in. So we have a module on each of those with exercises. And as I said, there's a community version, Beyond Anger and Violence, for women who have difficulty with anger. But again, it's going back and forth between the anger women have experienced, but also and what they have directed towards others, as well as what they've experienced. So when we talk about women-only treatment, you know, does any of this work? Does any of this make any difference? As I mentioned to you, in the specific interventions I've written, we certainly have research, and you'll find that on the website. But I want to tell you about this study because I think it's been an incredibly important study. You know, for years you can do work and believe in what you're doing, but often people more and more want to know evidence, evidence, evidence. And we now have had a 10-year follow-up study on long-term outcomes in a comparison between women who were in women's-only treatment compared to women who were in co-ed treatment. As I said to you, the majority of programs in this country are co-ed. But what they found, so for the women's-only treatment, these women were in women's-only treatment. For some of them, they were in a co-ed program, but the women only programmed with women. So the women's-only treatment was a combination of programs that were totally women-only or programs that took men and women, but the women were only in women's treatment groups. But when they compared those with women who were in treatment groups that were mixed, they found over 10 years that the women were more successful by 49% if they were in women's-only treatment. And they looked at 3 areas. They looked at their use of substances, they looked at their mental health, and they looked at their criminal justice involvement. And in all 3 of those categories, the women did significantly better if they were women's-only treatment. So I think it's wonderful to have a study sort of backing up from what many of us have felt and sort of known all along, if you will. There are also materials for staff because it's really important, as I said, there's training that needs to happen. That's that piece of the knowledge, becoming trauma-informed, but also figuring out how do we take that knowledge and then what do we do. So there's material on staff about becoming trauma-informed, particularly working with women in the criminal justice system. It's on a CD. It's a one-day training with a facilitator guide, a participant's booklet, and the PowerPoints for the training. There's a program that Sandy Bloom and I developed last year called Moving from Trauma-Informed to Trauma-Responsive. It's a program for organizational change. And in this program, you have a facilitator guide, you have 3 hours of DVDs, you have 100 pages of handouts that you can duplicate, and there's a process there where we explain how to move your organization from becoming trauma-informed to trauma-responsive. And then Women in Addiction, Gender-Responsive Approach is a program guide for developing women's services. So that gives you an idea of some of the things that I've developed that are out there to sort of, and hopefully keep moving us all along. You know, there's one fundamental thing. If you only take one thing from today's webinar, I hope it's this. And this actually came out of some work that Sandy Bloom did in the 80s when she was working and running a inpatient psychiatric unit and changing what they were doing in an inpatient psychiatric hospital where we can imagine what the traditional and know what the traditional mental health treatment was like at the end of the 80s. But they got it somehow that most of the people in this setting where people had trauma histories, and one day the staff was sitting around the table and saying, okay, well, things are really working better, people are getting better. What have we actually done and changed? And Joe, a social worker there, said, you know, we stopped focusing on what's wrong with people, and we started focusing on what's happened to them. And so this question that we so often use when we're working with women, and if we don't say it out loud, we say it in our mind, we say it around family members and friends, what's wrong with her? But if we shift that question to I wonder what's happened to her, it changes our attitude, and it also begins to change the environment, that culture that I said, of the treatment setting. So changing, just even changing this question can have quite an impact on services. As I begin to close, I want to invite you to an event that will happen next June in Connecticut. We do this conference about every 2 years where people have an opportunity over a course of 2.5 days to pick one of the programs, one of some of the materials that I've written, and get some in-depth training. So here's an invitation to this conference. This will be our 6th national conference that we've done on all of these various materials. And then I'm going to close with this slide, and then we'll be able to take questions. When any of you who know my work know that I like spirals a lot. And initially I used the spiral as a way to think about addiction and to think about recovery. But then as I was doing more and more trauma work, I realized the spiral works both for addiction and trauma. And here's how I think about this, that when a woman is addicted to alcohol and other drugs or has some kind of behavioral or process addiction, she's caught in a downward spiral and her life becomes more and more constricted. And that line through the middle of the downward spiral is the object of her addiction, and it becomes the organizing principle in her life. And she organizes her life around it. She organizes her life about when she's going to use or have it, the people that she's going to be with when she uses or has it. It just becomes the organizing principle, and it becomes very limiting. And it's the same for the trauma survivor, that very often the trauma survivor organizes their life around their traumatic experience or experiences. So there's certain places they don't go, certain people they can't be around. The limitation can be from having multiple layers of clothing or carrying extra weight. But there's this constriction and limitation in life. And then our task, our goal really is to help her move from this downward spiral of constriction onto the upward spiral of recovery and healing, which is the experience of expansion. So the woman with the addictive disorder is now moving up into recovery, and where now there are many more choices in life. Now, you'll notice there's still a line in the upward spiral, and that line in the upward spiral really represents the experience of addiction, or it can represent the experience of trauma. Every powerful life event stays with us all of our life, so it isn't gone, but it becomes a piece of her life experience, but it's not who she is. It's a piece of her life experience. And now she has the freedom and the ability to expand and grow. And this process I think of as having our inner life being our thoughts, feelings, beliefs, values, connected, that's our inner life, connected to our outer life, which is our behavior and our relationships. And you have those two things connected and congruent, so there's a sense of wholeness. So there's that sense of wholeness and expansion that comes with recovery from addiction and healing from trauma. And over the years, I can't tell you how many women have said to me, will those ever be gone? And to be honest, I have to say no, as I said to you. Just, every powerful life experience stays with us, but healing and recovery is possible. And often I use as an analogy a broken bone. We can imagine, let's say 30 years ago, I broke my arm, and my arm is now healed and is totally functional. But if I had a broken arm 30 years ago and I had an x-ray on that arm, the person reading the x-ray will be able to say, I see you had a broken arm. There will still be something there indicating that I had a broken arm. And it's the same thing with addiction and trauma. It's still there, but in a very different way. But the other thing that I'll be told is my arm is now strongest at the broken place. And that's what we want the women we serve to be able to experience. that in fact they become strongest at those broken places, that actually for recovery and healing to take place, there's a transformation. And she's able to say, who I am today is not who I was. So I thank you very much for joining me today on our webinar, talking about what it means to have trauma-informed addiction services for women. And then I think we're going to have an opportunity to do some question and answers.
This is Carla, and I do have some questions ready to go.
Okay.
Amanda asks, we know that in regards to suicide, men have a greater tendency to use lethal methods, and women do not due to lack, for a better word, etc. Do you believe that women are using prescribed opioids more due to the invasive nature of IV use?
Do I think that women are using opiates more? I didn't get the last part of the question.
More due to the invasive nature of IV use.
I don't know. I've never thought about that. I don't know that that's why. I think women are using opioids more in order to numb themselves out.
I think it's using pills rather than injecting.
Yeah. Oh, possibly. But a lot of women inject other drugs. I mean, I don't know. Sorry.
Okay. We have another question from Suzanne. Stephanie, what are your thoughts on using the term trauma reaction instead of trigger? Some victim survivors have said that trigger is reminiscent of the abuse, violence they endured.
Sure, I think that wording, changing that wording makes sense. I mean, trigger is all over the literature and is used all the time. I think it's always good to look at, in fact, Carol and I have had many discussions in the last few weeks about language, such as substance misuse, for example. You know, people didn't like the language substance abuse, so they changed to substance misuse. Now we're looking at how that can be a pejorative. So I think trauma reaction is a good language change.
I think trigger, brings up the image of a gun and a trigger, so that there's that violent image embedded in it.
Right.
Okay. Suzanne also asks if there's time, would it be better to use the longer Beyond Trauma curriculum with a group of women living with relationship abuse-related trauma? Better meaning more successful outcomes.
You know, we've had successful outcomes with both, and what I would say is it really depends on, I'm finding that for some places, a 12-session intervention, the women aren't there long enough for the 12 sessions. So I think it really depends more on if the women are going to complete the intervention. So sometimes, depending on where women are seeking services, a 6-session intervention works better because they'll complete it. So it really depends on where the woman is seeking services. But research outcomes are good on both.
All right. Let me see. Will there be scholarships available for the 2019 Women's Conference?
I don't know. The Connecticut Women's Consortium is the host and sponsor of the conference, and they're the ones that determine those kinds of details. On the website, there will be a link to the consortium. If you look at my website, there'll be a link to the conference, and on that page will be a link to the consortium, and you'll need to ask them about that. Those are the kinds of details I usually don't know till the last minute, if I ever know them.
Okay.
I wanted to add one thing, Carla, and
Sure.
this is around using Beyond Trauma and the shorter version and DV programs, which I know a number of programs have used, and I think there's also a difference whether you're using in a residential setting and how long people are there, or if it's a walk-in setting and whether it's safe for someone to keep regular appointments, and as they start to heal and recover, does their partner notice changes that they may have to be kind of mindful of so they don't actually show them when they're home if they're still living with someone who's abusive. There are lots of things to think about when someone's still under siege, and we're doing all of these wonderful approaches to factor in the layer when you're thinking about ongoing domestic violence and when people are still at risk.
Yeah, I think we also talk to facilitators because everything has a workbook or a journal, and we talk to facilitators about being sure that there's a sense of safety and confidentiality around the workbook, that sometimes women cannot take these things home. So we suggest the facilitator get a plastic envelope that with a woman's name on it, that her journal can go in there, and she can put a sticky to seal the label to know it's, no one has looked at it, and then not take it home. We find the same thing sometimes with girls in the girls program. They can't take materials home. Same issue of it's not safe.
Okay. This is more of a comment than a question, but I'll read it anyway. The ACE survey is a great tool. However, it only takes into account contact sexual abuse and not non-contact sexual abuse. That excludes, overlooks a good number of people who have been traumatized in that sense.
Yeah, well, I think the ACE study, let me talk about pros and cons. The pro is it was ever established and used with such a significant number of people, and then the research showing connections. But those 10 questions do not take into account all the various kinds of traumatic experiences that people have had, and it's limited in that way. And certainly when we look at sexual abuse in both helping women recover and beyond trauma, we talk about sexual abuse on a continuum from the psychological sexual abuse, the covert abuse, and the overt abuse. So I totally agree with you that only looking at contact or overt sexual abuse limits what can happen for women, and that is a limitation of the ACE study. It is not it's not a comprehensive trauma tool.
Okay, I have another question. Do you think, and this, let me see if there's another one. Yeah, I have two questions that are very similar, and the last one is, do you think that men are affected the same way that women are?
We've developed gender responsive. When we talk about gender responsive, for years that was synonymous with female. We now have gender responsive materials for men. And what we have found with our men's, they have a helping men recover, so it's addiction and the sub-theme trauma, and then we have a 6-session intervention for men called Exploring Trauma. Again, we have lots of research on that, particularly we have some in the community, lots in criminal justice. And no, men respond to trauma differently in some ways, but I can tell you, as hesitant as people have been to do trauma work with men, I mean, they said things like, well, men won't talk about trauma. Well, that isn't true. For men, there's a greater risk to externalize and act out, and for women to internalize and to move inward. And I say that as just a generalization. But when I'll give you an example, though, about being trauma responsive with men. What we found is, male socialization in this country and many countries, what are the messages we give boys? Be strong, do it alone, fight back, don't cry. We have all these messages. So then when a boy or a young man is harmed, there's a lot of shame about feeling vulnerable, or shame about feeling like you didn't or couldn't protect yourself. And so the level of shame that we work on with men is different, and the way we approach this is different. So we have interactive exercises, but they're designed differently for men, and it's done through the lens of male socialization and then how that connects with their traumatic experiences. So I think we've neglected work with men around trauma, and I think it's incredibly important, but it is different. I wouldn't take one of the women's trauma programs and change the pronouns to he and then give it to a man. Just, you know, it wouldn't be good.
Okay. Are you aware of any literature regarding brief concurrent treatment for trauma and addiction for women in the medical hospital setting, and/or interventions that could be particularly helpful to these women when in a medical hospital?
You know, the only brief, quote-unquote, interventions done with women in a medical setting is detox. You know, medically monitored detoxification. I don't know of any brief thing that comes to mind for women in that setting. I think in that setting, and I'd be curious what they mean by brief in a medical setting. To me, that probably means 3 to 5 days, but I don't know what she's thinking about in terms of brief. I think you can plant seeds, and you can make suggestions, and you can provide resources. And I actually think, you know, in terms of trauma, we can do something in 10 or 15 minutes with anyone. And I have something called a brief conversation. I don't know if we put it up on the website or not, but if it's not, it will go there with a link to it. And it's really about saying to someone, you know, many people that we see here, wherever here is, often have had really difficult life experiences. I don't know if that's true for you or not. And a person can answer whatever way and say, well, we've learned a lot about how to help people, and I can certainly provide resources in case you're interested. And we also know that very often just my being here with you and talking with you about this intake or whatever your role is can be uncomfortable. And so I have a couple of tools that I could demonstrate for you in case you're interested. And again, they can say yes or no. And if you don't want me to demonstrate them, I'm happy to hand you this card that explains them. And on that, you have the 5 senses activity on one side, and on the other side, you have a breathing exercise. And so you can hand that to someone. And so I believe we can do that in any setting in a very short period of time.
Okay, there's another question. Mental health first aid is very popular in our area. Can you speak to the trauma-informedness of this approach?
Actually, I can't. Okay, Carol, can you?
I don't think I could do it right now because I haven't been immersed in it in a while. I think there were some concerns that people had expressed about it, but I'm not able to speak to it. So
yeah, same thing. I would say exactly the same thing.
Okay. Here's another one. I find it interesting that women use more addictive drugs than men. How was that discovered? Is that part of it because our needs were more addressed as our needs were not addressed as much as men, seeing that initially programs were made for men created by men?
Go back to the beginning part of the question. I find it interesting that, tell me what that part was.
Women use more addictive drugs than men. How was that discovered? Is that part of it because our needs were not addressed as much as men, seeing that initially programs were made for men created by men?
I don't know that I said that women use more addictive drugs than men. Women are using more prescription drugs. so you know, and I know that girls are more binge drinking more than boys, so I think I wouldn't say in general that women are using more addictive drugs than men do.
Some of the data that I've seen is that women are more likely to be prescribed prescription opioids. They're more likely to experience chronic pain. They're more likely to use non-medical use to manage emotional distress. And for survivors of trauma and DV who are more likely to experience chronic pain, that's another issue. When we did a study back in 1989 in the emergency room at Cook County Hospital, women were more likely to be prescribed psychotropic medication without anyone ever identifying the abuse. So practitioners were treating pain without actually finding out what was causing it, whether it was physical pain or emotional pain. Yeah. So.
Okay. That, I believe, is it on the questions. So, unless you have closing comments, I could close out the session.
Well, Carla, was there the slide? I might have missed it on the webinar that's on the 24th, announcing that one. Is it a couple slides back? I just wanted to make sure that people knew about that. It was supposed to be in the slide deck. Yes, here, yes. Just to remind you that the next one in our series, our joint series, and then we'll be sending out announcements about the future ones once we solidify all the dates. So.
Well, thank you very much, Carol, for having me on the webinar and for sponsoring this really important series.
And thank you, Stephanie, for doing this with us. It's really wonderful. And this will be the third webinar of yours that we have archived on our website. So we have a whole collection with materials, which we're really happy about. Carla, do you want to do the rest of the closeout?
Yeah, sure. Thank you again, Stephanie, for today's webinar, and thank you to Angelica and Carol for making the webinar run smoothly. Last but not least, thank you all for spending your time with the Center. Within the next week, we will send you all a follow-up email with a link to the recording of today's webinar, in addition to any slides and handouts referenced, all of which will be available on our website. You will also receive a certificate of attendance for your time today. At the end of this webinar, you will be taken to a very brief evaluation. If you could please take a moment to let us know what was useful and what could have been better, we would greatly appreciate it. Thanks again, and we hope you all have a wonderful afternoon.